In August of 2022, I was diagnosed with a very rare and severe condition called autoimmune encephalitis. This condition arose from the antibodies in my body mistakenly attacking and damaging my brain instead of the teratoma that I had present in my ovary. During the onset of the condition, I lost my ability to speak, walk, talk, or do anything autonomously. My rational way of thinking was majorly impacted, and my thoughts did not make any sense. I spent 63 days in both Atrium and Duke hospitals, and I was unable to attend my university for my senior year of college. Due to the electroconvulsive therapies that I endured, I suffered from extreme memory loss during my hospitalization. Learning to regain my motor skills and cognitive function has been a challenge of a lifetime. When my family and friends first noticed a change in my behavior, it was accredited to the end of a relationship with my previous partner. Once they realized that something was very wrong with my behavior and the things that I was saying, my parents rushed me to the emergency room. The doctor who I was assigned to at the emergency room was an Indian man. He refused to give me any type of brain scan and did not believe that anything was wrong with me, despite my parents pleading with him. After the doctor asked me a question and heard my ridiculous response, he finally came to the conclusion that I did indeed need a scan. The scan he conducted was a CT scan, which is still one of the most basic of body scans. The CT scan came back negative. When asked by my mother the difference between a CT scan and a brain MRI, he responded saying that there was no real difference. My mother knew that this was not true because she had done her own research prior to the conversation with the doctor. He thought that the major change in my actions was a side effect from edible gummies that I had consumed. It was not until I had a seizure in front of my parents that he decided to admit me into the hospital, but only involuntarily because he thought I was having a mental breakdown or psychiatric issue. Later on, my mother found out that this doctor lied about having the ability to admit me into the hospital without my parents' consent. One day, during my stay at Atrium Hospital, I was suffering from severe psychosis. My brain injury caused me to be out of control of my behavior. I sat up, looked around, jumped out of my hospital bed, and ran down the hallway, screaming for my mother to help me. After this episode, the doctors automatically administered the antipsychotic medication haloperidol. Without doing any type of in depth research, they assumed that this medicine, commonly used for people with chronic psychosis, could alleviate the symptoms of my neurological injury. Patients with autoimmune encephalitis are advised not to use haloperidol as a means to help with bouts of psychosis because it has adverse effects on the brain. The lack of research into a medical condition resulting in a misdiagnosis of effective treatment is a commonplace mistake that is way too familiar to Black women seeking medical care in the United States. Since the development of healthcare in the United States, Black women have historically been discriminated against by the healthcare system. Jim Crow laws in southern states prevented African American women from having equitable access to quality healthcare. Despite various initiatives to create a more equitable healthcare environment for Black women, medical prejudices are still present in today's society. According to a 2017 observational study, non-Hispanic Black women are 3.4 times as likely to die from childbirth than non-Hispanic white women. Younger Black women are also more likely to report negative experiences in a doctor's office than any other ethnic and gender group.
Hi, I am Mia White. I am currently a junior at Hampton University. I'm from Raleigh, North Carolina.
Okay, thank you. And our first question is what was your experience with autoimmune encephalitis?
My experience kind of was from what I have been told. I don't really remember much of the actual experience, but after I graduated high school in June of 2020, yeah, 2020, a couple weeks later, I was just kind of acting funny, like to my parents, like was kind of really, as they would describe, depressed, anxious. I wasn't sleeping very well, like not for like 2 whole weeks. I wasn't sleeping. And then my parents decided to take me to Wakeman Hospital, the emergency room, just to see what was up. And then they transferred me to Duke University Hospital, where I stayed from like the end of June to September 11th. So that was kind of my hospital experience. And then after, I was still doing treatment until like probably until like the next summer. Um, I eventually got off like some of the medication that didn't allow me to drive, so I got off of that probably in April, and then I was able to drive of 2021, and then able to drive. I took a class at Wake Tech in 2020 in the fall, and then I enrolled in Hampton University, which was where I was going to school before everything, uh, in the spring of 2021. And that's why
Okay, thank you. And is there anything that you can remember that you can kind of tell us about any of your days in the hospital, like what your day-to-day looked like, or what you were told it was look like?
I don't really know. I, for me personally, I don't really like to think about it because the way that I can explain it, it's like something that everybody else remembers that I don't remember. And then people ask me, "Oh, do you remember that?" No. So I don't really know. I know my both my parents they would take like shifts. So my mom would come in the morning, my dad would come in the evenings, or like so my mom would come from like let's say from 8 to 1, and my dad would come from like 2 to 6, something like that. I'm not really sure. I did spend my 18th birthday there, and my sister was not allowed to visit me, and like only for my birthday did they allow her to come, mainly because it was COVID. But
Mhm.
that's kind of what I remember from like what they told me. I don't really know anything about like, the day-to-day treatment in the hospital.
Mhm. Okay. How would you say that having autoimmune encephalitis has impacted the rest of your life?
Um, I think it has made me more, I guess, like receptive to other health issues or challenges that other people might be going through. In terms of like how it has impacted me, like in my day-to-day like actions, it hasn't really like at first it did, but now I'm kind of like past that point. But yeah, like now I think I'm kind of pretty much back to what my doctors would call like a baseline. But before then, it was kind of hard to do stuff like I would walk every day just to keep up. I would do like mind games, like mind activities. I don't really have to do those. I don't do those, but it was just like little things when I first got out of the hospital. Now it's, not, I don't do those things anymore, but it has made me more aware.
Okay. That's great. Um, During your time in the hospital, if you don't remember, like maybe your family told you or your friends, do you know if you faced any type of discrimination from your personnel on your medical team?
Um, I do remember like a couple instances that my parents told me about. The first one was actually at Wake Med, like very first night that I was taken to the ER. They had a psychiatrist come, and he asked like the regular questions, like of course they have to rule out everything. So they were asking if I had like used drugs or anything like that, which that's fine. But the psychiatrist, he wanted to essentially commit me,
Mm,
like without any further testing into what this could be. So my parents were like, no, that's not what's going to happen because they knew that it was something, it wasn't just like a mental health issue.
right.
So they wanted to go more in depth into that. Like according to my mom, I don't really remember this, but apparently he didn't even do like full examination. He was just like, oh yeah,
Mm,
you know what this is like.
yeah.
Let's, yeah. So that was like the main thing that I can remember. In terms of other discrimination, I'm not really sure. I know that I didn't really have like a lot of on my AE team. I didn't have any like black doctors, and there were only a couple black nurses. Um, so that's kind of I don't really remember, but that is one the story about the psychiatrist. That is one specific memory.
Okay. I definitely went like through something like that. They asked about the drug question. probably because of age and, like our different identities that we have as well. So that was definitely something that I faced as well. So I can for sure understand your frustration with that.
Yeah.
And would you do you think that any of the maltreatment, maybe like with that one instance, do you think it can be attributed to maybe like your race, your gender, your age, maybe one of your identities that you have right now?
Definitely race. Yeah, I think it just comes down to race because
Mhm.
I mean, yeah,
Yeah, we get it.
yeah.
Do you think that this is also my last question? Do you think that having a doctor that identifies closely with your race and gender affects your experience in the healthcare field? And that could be like in a doctor's office, you go to the dentist, the optometrist, just anybody that looks like you and that can relate to you more often. How does that affect how you experience healthcare?
Um, I think it does definitely affect how you experience healthcare because for me, like I see a lot of the stories on Twitter, on Instagram of like people in healthcare that don't, or patients who don't get like the proper treatment. And I would say like my parents always made sure that we had black doctors. Like my dentist is a black, or we just moved dentists, but my dentist is still a black woman. But my dentist is a black woman. My pediatrician is a black woman. I just moved to another black woman when that pediatrician closed. I don't know. Like everybody was black except for my eye doctor. So I don't know. I think seeing that, and they're all black women. I
Mhm.
think seeing that for me was kind of like, okay, like they see me, like they understand, like, and it's kind of like it makes my doctors, I guess, seem more like relatable to me. Like my regular primary care doctor, she went to spell. My former dentist was like, it's just little things like that that make healthcare professionals connect with you on a personal level, and I kind of think that's important. So I would say like my experiences with white doctors haven't been bad, but I've just had great experiences with doctors.
Right. Gotcha. Okay. Well, that was my last question. Thank you for taking time out on your Saturday morning to interview with me. I really appreciate it.
Of course.
Of course. Thank you for having me. My name is Liz Brown. I'm a speech language pathologist at Duke Regional Hospital. I work in acute care as well as inpatient rehab.
Okay, thank you. And our first set of questions is how common is anti-NMDA receptor autoimmune encephalitis? And what is the ratio of African American people who get it versus white people? Also, what is the ratio of women who get it compared to men who get it?
Yeah. I, given my clinical expertise and area, I'm not as familiar with the frequency of anti-NMDA receptor autoimmune encephalitis. So don't feel comfortable answering that first part, but I'd be happy to answer more of that like 2 and 3 question.
Okay. Okay, so question two is what symptoms do people who have autoimmune encephalitis display? What happens in the body when these symptoms are shown by the patient?
Great. So, as a speech therapist, oftentimes when we are consulted with someone that has an autoimmune encephalitis, a lot of the deficits and symptomology that we see are going to be changes in cognition, behaviors, movement, speech, and swallowing. So, I'll take just a small amount of time to kind of touch on each of those. With swallowing, oftentimes we see it more related to the catatonia that may be displayed. So, poor responsiveness to the stimuli in the environment or level of alertness versus if the patient has like a prolonged period of catatonia, thinking about debility versus atrophy from disuse of those muscles. And then because of their impaired cognition, thinking about attention toward the oral bolus. Um, for the purposes of this, and I'm sorry I didn't ask you before recording money, do you want me to also relate it to how it was when I worked with you as a patient or just in general?
No, that would be great. Thank
Yeah,
you.
I'd be happy to. So, when you first presented to the hospital back in October, thinking about for you, for a swallowing perspective with the catatonia, you were not engaging or initiating any movement within the environment. Um, and so it was more a delay of the oral phase of your swallowing. So initiating the swallow was very significantly delayed. But once we got past that oral dysphagia, the pharyngeal phase, so like the initiation of swallow and musculature to move the bullets down, looked good. So once we improved the catatonia, which improved with the ECT, but also just your level of initiation within the environment, you were able to initiate a diet pretty seamlessly within a week, I think, of admission, and within the next like 2 or 3 sessions that I started working with you, since I was not consulted until I think like 7 days later. When I think about cognition, I think about language, memory, attention, executive functioning, and visual spatial skills. So I think when we think about executive functioning, we think problem solving, organization, reasoning, and safety and judgment. For memory, we think more of working memory versus immediate, delayed, short-term, long-term. Attention, there's different kinds as well, alternating attention versus divided versus sustained. Behaviors being more that changes in like the catatonia and hallucinations, but going back more specifically to cognition, for you, I think the biggest areas were executive functioning, memory, and attention. Memory specifically, I think, was also exacerbated by the ECT that they were doing, but it was very hard for you specifically to retain information greater than 2 seconds out from presentation when we first started working together. So even being able to repeat a word back to me that I said was really difficult. When we think about attention, so sustained attention, so focusing on one task at a time was also very difficult. I think part of that was because of the processing. So you have a pretty significant delay in processing or comprehension of information coming in. So I might ask you a question, and then part of my prompt or cue to anyone working with you would be to allow for 5 to 10 seconds for you to process the information provided before initiating any prompt to support your answer. So allowing you 5 to 10 seconds to process the information and then get something out. So instead of asking a question and then an immediate follow-up, just allowing you time to process the information to get it out. Something else in the initial phases, because of those cognitive deficits, was thinking too about how we present information. So instead of asking an open-ended question, focusing more on like yes, no questions or giving you choices. So instead of asking, what do you want to drink? Because there's endless opportunities and options, thinking about, would you like ginger ale or Sprite? So providing you either a visual prompt, but also that verbal prompt and 2 options where it would be what we considered a closed-ended question was very helpful for you. For memory strategies, a lot of what we relied on in the hospital setting was external aid use. So we use those giant sticky boards, like sticky Post-it notes essentially, around your room to orient you to the day, time, reason that you're there, the people that are there, and why we're there to help you. Just to provide that constant reminder that you're at the right place. This is what happened. This is the day, the time, the year, the month, because orientation was very difficult, but also just understanding the need to be in the hospital and why this happened and the severity of what we were seeing in that time frame. From a behaviors perspective, thinking again, what we would typically see with someone with autoimmune encephalitis would be that catatonia, so poor or limited no response to the environment, and then also like visual auditory hallucinations. So seeing things that aren't actually there versus auditory hallucinations, so hearing things that aren't actually happening. I know that I think at nighttime you may have had more experience with the hallucinations versus the daytime when I typically saw you in the hospital. And then the other big area that we saw or that we can see with autoimmune encephalitis is more of the speech changes. So as an example, you might see a change in the rate of speech. So increased rate, you're talking very fast. Reduced range of motion of your articulators, so not opening up your jaw or moving your tongue, your teeth, and your lips as effectively. And so instead of saying, hi, my name is Imani Howard, it might have been, hello, my name is Imani Howard. And when we first met, that's exactly how it was. So it was very low volume. You barely opened your mouth or moved to communicate. And it was really hard to understand what you were saying. Now, from your perspective, you're speaking completely coherently and normally, and it made no sense why people were looking at you and not sure what you were saying. But that's just part of those speech changes that we can see. Not that it happens with every patient that has this, but some of those speech patterns that we can see that you actually did display whenever you first got to the hospital. As well as reduced intonation, naturalness, and cadence. So maybe an off pattern or very monotone. So like a flat affect, changes in the way that you interact and engage with people can also change. So I think those are the biggest symptoms as a speech therapist that we identify, look at, see, and we'll try and address in therapy. A lot of the therapy that we did together was thinking more about external aid use. So how can we modify the environment and provide you supports, visual supports, because your reading was wonderful, and then kind of educate you on ways for memory and attention strategies that you could use external strategies, but then also with repetition and modeled use to kind of internalize some of those strategies. So writing it down, repeating it, associating information, using all of those to help promote retention of information as well as be able to retrieve it later on. And I think that was, and then for movement, again, this wouldn't be necessarily something that we would touch on quite as much, but sometimes we'll see posturing where patients may have contractures in their body positioning that they're unable to initiate or voluntarily come out of. Some people can also have impacts on their respiratory system where they may need a trach placement. For you, that wasn't something that needed to be done, but we have had patients with autoimmune encephalitis that have needed subsequent tracheostomy placement to help them with their airway protection.
Thank you for that. And for my last set of questions, it's more like geared toward racial disparities that you might see in like the healthcare system and stuff. So for our third set, it's how do you think the disproportional balance of white doctors to African American doctors affect the patients that seek medical care?
So without having exclusively researched the topic, and in my limited experience in this healthcare setting, I feel like there could be an inherent distrust of doctors, and that could go back to the Tuskegee trials that they were still paying out in 2022, or other personal experiences with seeking care. But that could be correlated to the disproportionate amount of providers that are white versus African American. I also find that in my experience, patients that I don't know if it's because they are not seeking routine care, so that when African American patients do present to the hospital, they're oftentimes more acutely ill, and potentially needing more emergent interventions at that time. And so when we think about when they are getting to the hospital, if they do need more involved levels, and again, at times emergent interventions needed. Again, I don't know if this is because of like a distrust of providers. It could be limited healthcare coverage, so not having insurance, so not seeking medical care that they're not able to afford, despite race. Be able to go to the doctor's office to have those like routine health exams to see how they're doing. So when you don't have routine health exams, right, sometimes these comorbidities can kind of compound that the patient or person may not be aware that they have type 2 diabetes, or they may not be aware that they have congestive heart failure. So then when they do become ill, all of these comorbidities that maybe they didn't necessarily know that they had are compounding their hospital stay and making it harder for their recovery process. And then also thinking about transportation can be a barrier. So being able to physically access the medical care that's needed can make it harder. Again, just kind of taking it from routine healthcare annually to see what's going on to versus someone that only seeks care when they're emergently ill. I think that would be one of the bigger things that I think of. So I'm sure that patients want to see providers that look like them, that they feel comfortable with, that they can relate to more readily. And so there's this, I'm sure, inherent distrust based on history and based on personal experience that can kind of compound all of that as
well. And one other question, it's more about gender between men and women, and also non-binary people or those that don't identify as a certain gender. Do you think there is a presence of disparities between patient care and people who identify as different genders or don't identify at all?
Right. I definitely feel that there is, again, with limited explicit research in the area, thinking about gender bias. My knowledge and kind of where I'm coming from in my thought process here would just be looking at like maternal mortality rates around giving birth. So we know that the incidence of maternal mortality is much higher than what we would anticipate being for what we would consider a routine procedure that's happened for forever and ever and ever as we continue to populate the world. So understanding that, I would anticipate and understand that males often would receive better care than females whenever they're going to the hospital, going to seek out care. I would anticipate that would probably be a larger discrepancy when thinking about like particular areas, whether it be for like cardiac care. I think oftentimes we think about males having heart attacks and not women, whether or not that's true, right? So thinking about as a provider seeking out care, or as a provider, like providing care to a male versus a female, that may be lower on their differential based on generalized bias based on gender. I would also think that when we think about differences in gender, research over time is often done with males versus females. And so I think there's just like an overall lack of understanding of female anatomy, female research out there to kind of support the information, in part because people don't really want to test on reproductive age females versus pregnant females without knowing the repercussions that may have on their fetus. So I think that's also a consideration. So just like lack of knowledge or experience, understanding that the female gender could also be a reason or cause for disparities. But I would anticipate that there are disparities between males and females seeking medical care, and that the disparity would be that males receive a higher quality of care with better outcomes versus females.
And you kind of answered my other questions like in that same area with your answer, so I won't ask those. But yeah, that was the end of my set of questions. So thank you so much for answering them and taking time out for me.
Of course, I'm always happy to do it.
In the 2022 Physician Specialty Data Report from the Association of American Medical Colleges, it was found that out of the 950,000 active physicians in the United States, nearly 64% were white, 20.6% were Asian, 6.9% were Hispanic, and 5.7% were Black or African American. The unequal ratio of Black doctors to white doctors highlights the lack of representation of African Americans acting as primary care physicians. This could lead to mistrust of physicians by their Black patients and implicit racial bias by white healthcare workers. In 2021, out of all active physicians in the United States, only 37.7% were female. The small percentage of women working as physicians contributes to female patients not feeling as heard or comfortable with confiding in their primary care physicians or other members of their healthcare team about the conditions of their health. This could lead to women living with sicknesses that could be treated due to an absence of trust in their physician who they cannot identify with. For African Americans, the average annual premium cost of healthcare is nearly 20% of the average household income, which is an extreme barrier due to economic income inequalities in our society. An issue brief by the Office of the Assistant Secretary for Planning and Evaluation, the principal advisor to the Secretary of the U.S. Department of Health and Human Services on Policy Development, observed that since the implementation of coverage by the Affordable Care Act, the number of uninsured, non-Latino, non-elderly Black Americans had decreased from 20% in 2011 to 12% in 2019. White Americans had uninsured rates ranging from 7% to 8% in 2019. Not having adequate coverage for medical procedures, visits to the doctor's office, and life-saving medications significantly affects the opportunity for Black Americans to have access to equitable health care. The combination of inadequate number of active Black physicians compared to the amount of white physicians in the United States and the strain of expensive healthcare premiums that strangle the Black community create a cross-sectional issue of discrimination that has a detrimental impact on the experience of Black women in medicine. In order to minimize the negative encounters Black women have in healthcare environments, we have to be able to acknowledge that the maltreatment of Black women in the medical field is a cultural dilemma in our country and begin to brainstorm solutions to this problem. One possible solution includes increasing the amount of Black female healthcare workers in hospitals and in primary care offices. By raising the number of Black female medical personnel, it allows there to be more representation of Black female voices in important medical decisions, as well as more trust flowing between Black female patients and their physicians. This could also cause an upsurge of the amount of aspiring Black female physicians due to there being a precedence of excellence set by doctors they can closely identify with. Another response to this ongoing problem could be to educate doctors, nurses, and other medical personnel about ways to make their Black female patients feel comfortable during their visits. Widespread education about implicit racial bias, the historic exploitation of Black bodies by medical personnel for scientific gain, and gender discrimination would give physicians a new perspective and allow them to engage with their Black female patients in a way that is beneficial to both parties. Lastly, community forums between women of color and their local healthcare centers can be facilitated to allow for the medical workers to think of ways to become more inclusive in their practice. Doctors actively listening to the concerns of Black women in their local areas about commonly shared medical injustices that Black female patients have endured and taking action against them can result in powerful policy and practice changes that will begin to break down barriers that are put in place for a system that does not value the life of a Black woman in America. Black women in America deserve better experiences in the healthcare field. We work just as hard in all parts of our lives, only to receive half as much from the ones who are supposed to take care of our health needs. African American women should not have to earn the right to basic human health care. It should be given to them as a citizen of the United States of America. I hope that in the future, Black women in America will not have to choose between living with the detrimental effects of a potentially life threatening illness and misconduct by their physicians due to racial and gender bias.